Our next speaker is Dr. VAISHNAVI Madhavan, Consultant Cataract Glaucoma Pediatric Neuroophthalm at the Department of Eye Foundation Group of Hospitals. And she is going to be talking on structure-function correlation, a simplified approach. VAISHNAVI, you have to be concise. We have one more speaker. On to you.
Yes, ma'am. So at this juncture, I would like to thank Dr. Chitra Madam and AIOS for giving me this opportunity. So as we all know, standard alternate perimetry is a gold standard, and around 20 to 40% of the retinal ganglion cells are lost before any visual field picks up the defect. This could be attributable to the adaptive strategies like pre-retinal locus and oculomotor re-periphery. And there are few trials which has found out, they have assessed the structural and functional parameters, and they have found out that the progression of glaucoma is higher when the patient has got a higher baseline intraocular pressure, and in case of old age, bilaterality and disc hemorrhage. And coming to few case scenarios, our 55-year-old male patient came for routine checkup. His corrective visual acuity was 6/6, intraocular pressure was normal. He's a non-smoker and not on any antihypertensives. And you can see the right disc is almost normal.
VAISHNAVI, can you switch off your video?
You can see the inferior scotomas with the corresponding.
VAISHNAVI, can you switch off the video because your voice is not coming clear. Signal is poor. Switch off your video, okay, then your talk would be clear. You switch off your video. Keep your don't mute yourself. Yeah, now carry on.
So you can see the right eye disc is almost normal, and left eye shows inferior thinning and the notch with the corresponding RL nephil defect, and which is picked up on OCT as inferior thinning. But fields in the right eye showed normal, and left eye shows a small inferior and focal scotomas. So he was started on anti-glaucoma medications, and he was advised for yearly follow-up. And another patient is a 64-year-old male patient who came with the defective vision in the left eye, and the intraocular pressure was 22 in the right eye and 28 in the left eye. And the right eye vision was 6/12 and left eye was 6/36. He has got nuclear sclerosis grade 2 in both his eyes with a normal central corneal thickness. As you can see both here, the inferior notch corresponding to the superior field defects in both his eyes with the corresponding inferior thinning on OCT. So he was advised phacotrabeculectomy in the left eye followed by right eye. This is yet another patient, a 43-year-old male patient, came for regular checkup. His best corrective visual acuity was 6/6 in both eyes. There is no family history of glaucoma. Intraocular pressure was normal, and there was open angles on gonioscopy. You can see from this picture, it is almost 0.8 to 0.9 cupping. Here you can see in the left eye, you can see a splinter hemorrhages with the inferior thinning and a notch with the corresponding RNFL defect. And in the right eye, it shows a nasal step, and left eye shows a focal scotoma. And OCT shows inferior thinning in both the eyes, suggestive of normal tension glaucoma, and he was started on prostaglandin and advised yearly checkup. This is a 70-year-old male patient. There's no family history of glaucoma. Intraocular pressure was well within normal limits, and he had open angles on gonioscopy. And you can see the cup is very much enlarged, around 0.9. The OCT shows bipolar thinning in both the eyes, but the fields fail to pick up any scotomas except some focal defects in the left eye. So to treat or not to treat. So because intraocular pressure was under control and there was no family history of glaucoma, we decided to just observe the patient and serially follow up with the 6-monthly fields. This is a myopic 64-year-old male patient. His intraocular pressure right eye was 32 and left eye was 30. He was having open angles on gonioscopy. And you can see from this fundus picture, there was a very large cup around 0.9, almost eroded rim with extensive peripapillary atrophy, and left eye disc was almost normal with a peripapillary atrophy. So right eye fields showed advanced defect, and you can see the OCT showed gross RNFL thickening, which could be attributable to the 4 effect also. So he was advised anti-glaucoma medication followed by phacotrabeculectomy and a very guarded prognosis. And this is a 54-year-old male patient. Right eye vision was 6/60, left eye was 6/12. Intraocular pressure in the right eye was alone 32, left eye was normal, and he had got a pseudo-exfoliation glaucoma with open angles on gonioscopy. You can see from this picture, left eye was absolutely normal, and right eye showed bipolar thinning with the superior scotomas and bipolar thinning on the optical coherence tomography. So he was advised anti-glaucoma medication followed by phacotrabeculectomy in the right eye. So here you can see the superior thin with the superior field effect, superior thin on the OCT with the inferior thin, where the fields and the OCT are typically correlating. And this is another patient of 46-year-old female patient with the corrected visual acuity of 6/60 with nucleus sclerosis cataract in both eyes. And intraocular pressure was 10. You can see the cup was kind of a little bit enlarged, but the field were normal. But OCT picked up a few inferior thin. So this is a patient of perimetric glaucoma. But since again the intraocular pressure was normal, field defect didn't show anything. Just for the OCT alone, we decided to observe the patient and follow up every 6 months once. And this is a 78-year-old male patient with the intraocular pressure was 12. Best corrected acuity in the right eye was 6/6, left eye was 6/12. He gives history of retinal laser done 10 years back in the left eye. And you can see right eye fields were normal and left showed few central scotomas. And here you can see the IS disjunction with the RP thinning on OCT. So this is a case of atypical retinitis pigmentosa patients with a central scotomas. So from this, what I want to infer is all central scotomas not necessarily be glaucomatous. Always look for the retinal causes. And this is a patient of left eye optic disc pit, maculopathy. And you can see the superior scotomas and inferior thinning on OCT. This is a high myopic disc with a highly tilted disc, as it was discussed earlier, with few superior scotomas and OCT in the left eye. And here we might not rely totally on the fields and the disc for tilted disc and optic disc because it might give for falsely erroneous readings. This is a nice case of 56-year-old male patient who came with the complaints of headache. Best corrected visual acuity was 6/9 in the right eye, 6/12 in the left eye. Intraocular pressure was normal. And since the disc was little suspicious, we went ahead and did the visual fields, which showed a inferior quadrantic field defect. It was a typically pie on the floor defect. We went ahead and did an MRI scan, which showed a right parietal infarct. And this is at another patient of 46-year-old who complains of right-sided field defect. Vision was normal, intraocular pressure was normal, and the field shows right superior quadrantinopia, typically a pie on the sky. And MRI showed left temporal lobe tumor. And this is a 45-year-old female with a headache. Vision was 6/12 in the right eye and 6/9 in the left eye. Normal intraocular pressure with suspicious disc. We went ahead and did a fields, and to our surprise, it showed a right temporal hemianopia with a binasal thinning on OCT. So MRI showed a pituitary macroadenoma with suprasellar extension. And this is a 77-year-old male patient who complains of right-sided field defect for the past 3 days. Vision in the right eye was 6/12, left was 6/6, fundus was normal. And the field shows right homonymous hemianopia. MRI brain showed infarct in the left occipital region. Another 49-year-old male patient with right-sided field defect for 2 days duration. Vision was normal, fundus is normal, and you can see the field showed left homonymous hemianopia. An MRI brain was done, which showed non-hemorrhagic infarct in the right BCP territory. And you can see the optical coherence tomography was almost normal. So usually OCT picks up defects in the lateral geniculate body. So on the lateral geniculate body, it requires a transsynaptic degeneration to occur, so which may take some time to appear to show it in the OCT. Another patient of 56-year-old male patient who is a hypertensive diabetic, and the intraocular pressure was 16. Color vision is normal. Right eye vision is 6/12. Left is 6/18. And you can see right eye has got an optic atrophy and left is a florid disc edema. The left eye field shows inferior altitudinal field effect, which is typical of non-atretic AON. And we did a MRI scan also, so which was normal, and he was started on aspirin and vitamin C. This interesting case of a 12-year-old boy who was diagnosed as glaucoma elsewhere on anti-glaucoma medication for 2 years on and off, and he came to our outpatient for regular checkup. Vision was 6/18 and 6/12, and intraocular pressure was a normal range around 14 and 13. So you can see typically it looks very much glaucomatous. And we did a visual fields which showed grossly depressed fields, both eyes. And you can see the MRI. So MRI shows optic nerve thinning, and there is a thinning of the splenium of the corpus callosum with the periventricular white matter thinning, which is suggestive of periventricular leukomalacia.
Ma'am, 1
so
minute.
The diagnosis could be optic disc excavation. Yeah, 2 minutes. And this is an interesting case of 35-year-old male patient who complains of headache for the past 1 month. There's no history of trauma, vomiting, or tinnitus. Vision both eyes were 6/6. Intraocular pressure was 12 and 11. Color vision was normal, but blood pressure was 210/120 millimeter mercury. And this picture shows typical florid dyschema, feature suggestive of hypertensive retinopathy. And right eye field showed a few central scotoma. Then we did a OCT scanning, which showed florid edema. And OCT enhanced depth image showed inward reflection of RP towards the vitreous. And then we went ahead and did a MRI scanning, which shows multiple T2 hyperintense lesions in periventricular and deep white matter region involving the parietal, frontal, and temporal lobes. And they suspected a kind of a renal mass, and then we did a limited renal screening, which showed a renal cell carcinoma, and referred to the nephrologist. He underwent nephrectomy. You can see 1 month post nephrectomy, the resolution of dyschedema on fundus photo, and this is 2 months post nephrectomy. You can see nicely the resolution of dyschedema on OCT. So astute clinician with the investigations give appropriate diagnosis, and careful interpretation of tests give rise to real disease. Over-reliance on tests give rise to rare disease. So finally, structure and function correlation still remains an enigma. Kindly correlate clinically and with intelligent interpretation. Working on it still continues. And remember, after all, it's just a machine. Thank you.
Thanks, Vaishnavi, for taking us through a variety of very interesting cases and quick diagnosis. I'm going to ask you a question, and maybe the expert panel could also answer. Why is it visual fields fail to pick up early glaucomatous changes?
That's what, ma'am, I told you. There are some adaptive strategies to compensate scotoma. So what happens is something called the cortical remapping. So this cortical remapping.
Can you stop sharing the screen?
Yes. So this cortical remapping, it generates a filling of the visual field effects. So it compensates for the gaps in the perception. So these are the basic strategies which compensate for the scotoma. And there's something called the pre-retinal locus. So these pre-retinal locus are discrete areas in the retina. So these contain the center of target image for 20% of the fixation interval. So all these things, they actually compensate for the scotoma, which is lost in field effect.
And
so anyone else wants to add? So, no.
Yes, Dr. George, Dr. Krishnadas, any thoughts?
No, madam, nothing to add.
And why is it that the fields cannot be replaced by the imaging device at all? Where do we get stumped, especially in the advanced field damages, advanced optic nerve damage? Why is it the OCT we get stuck as against the fields?
OCT has got a floor effect, advanced glaucoma. So fields, as such, the fields, we can do a progression in advanced glaucoma and see how much fields have progressed. But this is not the case in case of OCT because of this floor effect. Even advanced glaucoma and very high myopia, they fail to pick up it.
Dr. George, you have anything to add before we go on to a last speaker?
No, nothing. Just to emphasize that we are trying to preserve function in glaucoma. Yes. So which is visual fields takes priority over everything else. That is the aim of our treatment. That's just one statement.
Okay. Thank you very much. Dr. Gauri, shall I go on to the last speaker?
Please, I think we are running out of time. I think.